will move to the ultrasound-guided cervical foraminal epidural steroid injection, or we'll kind of discuss the terminology by the end of this lecture. So historically, all the cervical injections were done blind, and I've seen one of those cervical blind epidural injection where the physician was looking at CSF and relying on the airdrop technique. And as anesthesiologists in the past, they used to do a lot of interscalene block or stellate ganglion block blind. However, this is from the past. Now we need images to have to be able to reach our target and to have a safe trajectory to the target, and then to verify that our medication is reaching the target and to rule out that it's not going to anywhere else. The modalities that we have to date are X-ray, which is widely available and easy to use, and it's all the studies are validated by fluoroscopy guidance. The CT guidance, which is strictly used by radiologists. It's not very easy to access for non-radiologists. And the ultrasound guidance that we are discussing in this session, the advantage and disadvantage. However, is it accurate, safe, or the efficacy is still to be proven? One of the major limitations of ultrasound when we're talking about cervical injection is the acoustic shed, which is the ability of the bone to absorb all the wave and hide everything that is behind it. As you can see in the picture, everything below the bone will be dark, and we will not be able to see anything beyond the bony cortex. And when we're talking about transforaminal injection in the neck, maybe the term is not very accurate, and we need to change it to a selective nerve root block, because when we're placing the needle is extraforaminal, since with the ultrasound we cannot see beyond that bony contrast. And in one of the review, one out of the 15 injection were indeed in the epidural space. Maybe one would argue that it might be volume dependent, and if we increase the volume, we will reach the epidural space. And that was proven wrong, because when the volume was increased from 1 cc to 4 cc, it didn't change too much, from 0 out of 53 to 13 out of 53 to reach the epidural space, which is still not very important. It is not, the terminology is not accurate. The proper segment identification, we cannot be 100% accurate because of the anatomical variation, as we discussed before. And this was also discussed before. And the efficacy and effectiveness to date is not really proven. We do have a lot of retrospective studies with a lot of flows showing that ultrasound extraforaminal injection are comparative to fluoroscopy transforaminal injection. And what about the safety of those injections? So if you cannot really detect the vasculature in an accurate way, therefore those injections are not very safe to do. We remember the anatomy and all the vasculature around the neck area. So if this technique is not 100% accurate in detecting the vessel, therefore it cannot be proven to be very safe. And all the studies today, they are still relying on the fluoroscopy to verify the vasculature uptake. And all those studies also excluded any patient, any obese patient with significant body habitus, because with the ultrasound it will be hard to scan those patients. It might be reliable to detect small vessel, however, the sensitivity is yet to be proven. And when you see one of the leads of ultrasound saying that the inability to visualize critical vessels at the anterior posterior foramen does not mean that those vessels does not exist, it means something. So the technique is still not taught by APSIS, and to date we need more prospective studies and randomized controlled trial to prove the safety of those procedures. It is still extraforaminal injection, we cannot call it transforaminal injection. If we're planning to do those injections under ultrasound, a hybrid technique is more advised. And we should always discuss with the patient what we're really doing, stating that we're doing extraforaminal injection and discussing all the potential complications that you can get into by not detecting the vessel. This is a previous slide where Dr. Moose discussed the importance of the vessels in the neck. And you can see it's not, it's a complicated vasculature system in the neck. And it is important to identify those vessels when you're doing an injection. I'll go through the technique that is described in the literature. It is not something Ipsos is teaching, but this is taught. Where replacing the probe is here in between the transverse process, the anterior and posterior tubercle, which is way different than when we're doing our transforaminal injection using the fluoroscopy. The patient is on his lateral side. We use a linear probe to identify the transverse process. We start by scanning the neck. We start by scanning the neck to try to identify the correct segment. We move until we identify the transverse process, and then we move up and down. When we see the anterior tubercle missing, we know that this is the C7 level, and then we move up or down depending on the level that we're targeting. And then in plane, we introduce the needle to reach the space between the nerve root, that is a hypoechoic structure on this picture, and the transverse process, the anterior and posterior tubercle of the transverse process, and then place the medication. We can use Doppler as well to try to identify main vessel, and it will not, of course, identify the small vessel that we can identify with the live fluoroscopy and the SI. And this is another sonography of anatomical variation showing how the vessels can also uh, depend. So in conclusion, ultrasound had some potential advantage, especially having a real time guidance, does not have X-ray. It is challenged by multiple things such as identify the correct segment, documenting the correct target, and it is in the neck especially, it is blind within the confine of the bony foramen, and it is more accurately called a selective nerve root block than transforaminal injection. It may have a value in hybrid technique, still to be proven.